I am Dr. Gregory Boyce, and welcome to Mrftt HIV STI Echo. Today's session is, again, a very special session. Dr. Chris Behrens is going to give us an HIV and COVID-19 update on, as a usual, Friday session. I want to welcome all the persons who are with us for the first time. Again, this is part of our growing family. We really appreciate your presence. I hope you learn a lot. This is meant to be a participatory sort of exercise, so feel free to put questions in the chat box, raise your hand, and ask questions afterwards and participate in the discussion. We all want to learn, we all want to grow as persons, as professionals, and as carers. So that being said, I will turn over the floor to Dr. Behrens, who is going to give his presentation on HIV and COVID-19 update. Thank you very much.
All right. Thank you, Gregory. And it's, as always, an honor and a privilege to be here discussing these issues with you. And oops, this is strange. Okay, hang on. There we go. Okay. I'm going to give review a few selected topics on HIV and COVID. I have the usual acknowledgements of our sponsors, and I have no relevant financial disclosures. Our learning objectives are to summarize recent findings regarding the impact of COVID-19 on birth outcomes in pregnant women living with and without HIV. Review some data regarding the effectiveness of COVID vaccines amongst immunocompromised individuals. State the latest CDC guidelines from the United States regarding COVID vaccinations for individuals who are moderately or severely immunocompromised, and describe the risks of myocarditis and pericarditis that have been associated with the messenger RNA COVID vaccines. So let's start out by talking about some data that have emerged very recently from the Tsepamo study in Botswana regarding the risks of COVID infection among people infected with HIV. Now, we know that SARS-CoV-2 infection during pregnancy is associated with a significant increase in the risks of various adverse birth outcomes, including preeclampsia, stillbirth, preterm delivery. These were studies largely carried out in Europe, China, and North America. The image on the right of the screen is just one image from a meta-analysis looking at, for example, the risks of preterm delivery in individuals with COVID-19. And I just put that there as sort of an example of what we already know. But what we haven't really known is information on whether HIV influences that risk. And furthermore, those studies that have been done to date have largely been carried out in areas other than sub-Saharan Africa. So it would be helpful to know if COVID-19 increases the risk of adverse birth outcomes in pregnant women living with HIV. And so the Tsepamo study, in case you're not familiar with it, is a longitudinal ongoing study looking at birth outcomes among women in Botswana at 13 different sites in that country. And notoriously, this was the same study that provided an initial alarming signal that perhaps dolutegravir was associated with adverse birth outcomes. It's looking more and more like that is not the case. But at any rate, this is why you may have heard of this, the Tsepamo study. So for the purposes of these data, which were just presented last week at a major international conference here in the United States, they collected data on COVID-19 status at the time of delivery in participating hospitals during 2020 to 2021, and looked at the birth outcomes at 13 of these sites from September 2020 to November 2021. Notably, this was before the arrival of the Omicron variant in Botswana. Also important to note, very few of the women who were included in the study had been vaccinated against COVID because Botswana did not start vaccinating until late 2021, and they prioritized people over 65 years of age. At any rate, there were over 11,000 women that were tested for COVID-19. About 5% tested positive, 539 women, and of these, 144 of those were HIV infected women. The women with HIV, notably, were significantly more likely to test positive for COVID-19 at the time of delivery. And I guess that's not too surprising. We know that HIV can increase the risk of acquisition of SARS-CoV-2 infection. The difference was not tremendous, 5.6% versus 4.3%, but it was statistically significant. Now, the results, if we look overall at both HIV infected and HIV negative women, we find that women who were positive for COVID-19 around the time of delivery were more likely to experience adverse birth outcomes, such as preeclampsia, premature delivery, and stillbirth. Again, this is not surprising. We have seen that impact from other studies around the world. The risk of stillbirth was approximately doubled, and that's a very sort of troubling and dramatic finding. Also not new, similar to a study that was published in the United States by the CDC, looking at outcomes of COVID-infected women at delivery in the US. So just as we have seen elsewhere in this study, having COVID-19 increases the risk of adverse outcomes, approximately doubles the risk of stillbirth. Pathophysiology of that, not entirely clear, might be a consequence of disruption of blood flow and inflammation in the placenta. But it suggests that maybe if we can prevent severe COVID-19 illness, it might also reduce that risk. Now, one of the key studies we'd like to see answered, one of the key questions we want to get out of this study is what happens in pregnant women who are HIV infected. And among those women, adverse birth outcomes were substantially higher among HIV infected women who tested positive for COVID-19 as compared to HIV infected women who didn't have COVID-19. So essentially, we find the same effect among HIV infected women as HIV negative. COVID-19 substantially increases the risk of bad outcomes. And to drill down to some specifics, after adjusting for age, because of course we know age can affect the risk of adverse birth outcomes too. Women with HIV and COVID-19 had, as compared with HIV positive without COVID, a 78% higher risk of any adverse birth outcome, so nearly double. A 65% higher risk of a severe birth outcome, also really alarmingly high. Twice the risk of preterm delivery or very preterm delivery, and 65% higher risk of having a small for gestational age infant. Now, interestingly, in this study, they did not see a big impact on the risk of stillbirth or neonatal death. But I think the bottom line is, we find that pregnant women exposed to both COVID-19 and who have HIV have the highest risk for most of these adverse outcomes. We know that HIV itself increases the risk of adverse outcomes, especially if the mother is not on treatment. There are data that finding that ART does reduce the risk of adverse outcomes, but does not eliminate that increased risk. So I think it's kind of calling out usefully the importance of both getting antiretroviral therapy on board and vaccinating are HIV infected women who may become pregnant or are already pregnant. So we really should, to be clear, be vaccinating women of childbearing age, just as we would be vaccinating anyone else who meets vaccination criteria. Furthermore, women who are already pregnant, it is by no means too late to give the vaccine. They are safe and effective for pregnant women, and we have lots of evidence for that. And this is just one report that was published last month, showing that giving pregnant women the COVID vaccine during pregnancy significantly reduced the risk of their infants being hospitalized subsequent to delivery. So I hope this is sort of useful information to sort of redouble and reinforce our efforts at persuading women of childbearing age and those who are already pregnant to go ahead and get vaccinated against COVID. Now, let's talk about how well the COVID booster vaccines work for people living with HIV. We are starting to accumulate some data on this front, and it's always been sort of a frustration that we get this information about how effective the initial series is, how effective the booster series is, but it's always very difficult to discern, is there any difference in those effects for people who have HIV disease. So this was a study that was also presented just last week at the same conference. It's an analysis of breakthrough infections and severe COVID in people who had received an additional or booster dose after full vaccination. 60 hospitals participating in this COVID Cohort Collaborative here in the United States. It compared outcomes in people who were immunocompromised and fully vaccinated according to whether they had received a booster dose or not. The study population consists of people who have been fully vaccinated by the 17th of December and followed until January of 2022. Full vaccination being defined as 2 doses of one of the 2 mRNA vaccines or 1 dose of the Johnson & Johnson. So overall, and we're talking pretty big numbers here in this study, which is helpful. Over 600,000 people have been fully vaccinated. Of these, 174,000 had received a booster dose. And just to be clear on what we mean by immunocompromised in the context of this study, people were defined as immunocompromised if they were living with HIV, had cancer, autoimmune disease, or had undergone a solid organ or bone marrow transplant. Now, the relative proportion of how many of these in this sort of immune dysfunction group were people with HIV was not stated, unfortunately. So it's sort of hard to tease out from the other groups just how much was specific to those with HIV. But nevertheless, I think this gives us some important insights. So here are the results. So during this follow-up period, about 50,000 of the fully vaccinated cohort became infected with COVID, with SARS-CoV-2, had COVID-19. Now, approximately 20% of those, or 9,000 infections in those fully vaccinated, occurred with the Omicron variant, with the other 80% presumably Delta. When we look at breakthrough infections in people without immunosuppression, we find that the vaccine efficacy against breakthrough infection after a booster dose remained high 7 months after full vaccination, but fell thereafter by 9 months from about 77% to 52%. And then this corroborates data we have seen elsewhere. The booster dose definitely helps, but its efficacy, at least in terms of preventing any kind of COVID illness, tapers off after about 6 to 7 months, and we start to see a waning of the effectiveness. Now, in immunocompromised people, The booster vaccines also worked, reduced the risk of breakthrough infection, but that reduction in the risk was not quite as strong as it was in those without immunosuppression. So just to drill down to the specific numbers here, 9 months after full vaccination, the boosted individuals had about a 44% lower risk of breakthrough infection as compared to those who were not boosted. And the researchers calculated that the booster vaccine, that with a booster, the efficacy was about 39% at this time point. Boosted individuals also had a significantly reduced risk of severe COVID-19 outcomes, defined as reducing the risk of being admitted to a hospital or dying of COVID-19. Specifically, receiving a booster dose reduced that risk by over 85% in people without immune dysfunction and approximately 80% in people with immune dysfunction. So to me, that's a very striking finding, that even with immune dysfunction, and some of the individuals in this group have fairly profound immune dysfunction, you still get a very, very strong high-level reduction in the risk of severe COVID-19 illness that really just about matches the level of protection seen in those without immune dysfunction. So I think this makes a really strong case for pushing and advocating for that booster dose in our people with HIV. Obviously, it would be helpful to know just how many of the people in this cohort had HIV, to try and tease out or stratify by CD4 count and level of virologic suppression, et cetera. And hopefully we may get more data on this later. Again, this just came out last week as an abstract at this conference. But nevertheless, the preliminary findings regarding just how useful booster doses are for those even who are immunocompromised, I think deserves a lot of attention, and hopefully might help to persuade our people with HIV to go ahead and get the booster vaccine. Now, let's talk about what the latest guidance is from the United States CDC on this issue, because I think it sort of nicely summarizes in concrete terms how we should logistically be doing this. And so these are updated recently by the CDC. They can be found on their website. I think they're applicable to the Caribbean region as well. And just to be clear, these guidelines that I'm going to cover talk about those individuals who are moderately or severely immunocompromised. And to fit in that category, you have to have be receiving active cancer treatment, have received an organ transplant and are taking immunosuppressive medications, received a stem cell transplant within the last 2 years, or taking immunosuppressive medications. Moderate or severe primary immunodeficiency, and here, importantly, advanced or untreated HIV infection, which is typically defined as either not on ART or having a CD4 count less than 200, or both. And then the last criterion that would qualify for this group: active treatment with high-dose corticosteroids or other drugs that may suppress the immune response. So here, think about all the various drugs to treat rheumatologic disorders. So with that definition in mind, we should also review the definition, because this is another source for confusion among patients and some providers. What are we talking about when we say a booster dose as compared to a third primary dose? So for people who are significantly immunosuppressed, it's recommended to get a third primary dose of messenger RNA vaccines. So rather than getting just two vaccinations as part of the primary vaccination series, typically about a month apart, we recommend you get 3 initial shots as part of that primary series. And then that can be followed by a booster, and in this case, the booster would actually be a 4th shot. So to spell it out according to age group, children ages 5 to 11 years of age who are moderately or severely immunocompromised. What's recommended here in the United States is the Pfizer messenger RNA vaccine. It's the only one here in the United States that has been authorized for this age group. And those and children in this age group who are immunocompromised should get the 3-dose primary series. And actually a booster is not recommended at this time. That may change with further research, but at this point it's still just a 3-dose primary series with the Pfizer vaccination. Now for older children, teens, and adults, options include the Pfizer or the Moderna vaccinations. Now, the Moderna, at least here in the United States, is only recommended or endorsed for those individuals 18 years and up, whereas Pfizer captures those who are 12 years and up. And for these individuals, a 3-dose primary series is recommended with the timetable that is shown there, followed by a booster. And that booster, whether we're using the Pfizer or Moderna vaccine, should be given at least 3 months after completing the primary series, which means at least 3 months after that 3rd dose. Now, the Johnson & Janssen vaccine is not preferred here in the United States, at least, but it can be considered in some situations. Those people who have received that already and are moderately or severely immunocompromised, it's really recommended that after that 1st dose of the Johnson & Johnson vaccine, which was initially marketed as a single shot, should get a 2nd dose, but that 2nd dose should be one of the messenger RNA vaccines, either Pfizer or Moderna, and it should be given at least 4 weeks after the 1st dose. And then a booster should be given, again, with either one of the messenger RNA vaccines, usually given at least 2 months after that 2nd dose. So there's some sort of, I think, broad trends in this, but the details are a little tricky, and it's worth keeping these in mind. This is a graphic that tries to sort of summarize what we have just covered about the timing and when the booster doses should given. So interestingly, for the I'm sorry, and what you will notice is that it's not showing, it's only showing the ages 5 to 11 years actually should not receive a booster dose, which is why it's so important to pay attention to that asterisk on the far right for the booster doses. Okay. Now, there are a couple, sort of commonly asked questions that I think are also reviewing. Just how well does a 3rd primary dose help? And we have some evidence that it does, even if people don't seem to respond to the first 2 shots. This can actually be measured with tracking monoclonal antibody levels. However, it's much more difficult to track the T-cell response to vaccination. So I know I have some patients who are immunocompromised, have gotten the initial 2-shot series, subsequently had a blood test to measure the levels of neutralizing antibody against COVID, and they come back negative. And that's discouraging, but it doesn't mean that there's zero impact, because when we talk about vaccinations, there's really two arms of the immune system that are recruited by the vaccines. The humoral immunity, think B cells and antibodies, that we can easily measure, but the T cell response or adaptive immunity response, that is a lot less easy and to measure, and frankly, it's very possible that individuals who are getting these vaccines may be getting significant protection in terms of the T-cell response. In fact, there is some evidence to that effect. The next question often comes up, well, what are the risks of vaccinating people who are moderately or severely immunocompromised with a third primary dose? While this continues to be evaluated, but we're just not seeing any increased risk. It looks pretty much the same as with the first couple doses. Usually side effects are mild, rarely severe side effects, but it's not like people who have advanced immunocompromise are at any higher risk from these vaccinations. Now, one thing you may be hearing about, though, is these specific cardiovascular complications of COVID vaccination. And I know there's been quite a bit of misinformation out there about what the risk is. So I'm going to spend a few minutes sort of reviewing what we know about that, because I think it's important for counseling your patients and trying to counter whatever misinformation you may be finding out there. Here we're specifically talking about myocarditis, which is inflammation of the cardiac muscle, and pericarditis, which is inflammation of the membrane that surrounds the heart. And there were initially case reports of pericarditis and myocarditis that were cropping up following vaccination with the messenger RNA vaccines, the Pfizer and the Moderna vaccines. And the CDC certainly continued to recommend vaccination appropriately, but initially we just didn't have a big grasp of exactly what was the scope of the problem here, just some case reports. Hopefully we now have a bit more information. This was a study published late last year from Israel. Israel, as you may know, has got an enormous supply of the Pfizer vaccine and really set about trying to immunize their entire population. And they have been studying the heck out of how well the vaccine has been working and side effects, et cetera, et cetera. So a lot of useful information about the Pfizer vaccine comes first out of Israel. In this study, they retrospectively reviewed data from December 2020 to May of 2021 regarding all cases of myocarditis. And so they identified 304 persons who had symptoms. 21 were diagnosed with someone else. Of the remaining 283 cases, 142 of these occurred shortly after receiving the Pfizer vaccine. And of those 142, they narrowed it down to 136 diagnoses that were definitive or probable. So these were the cases they were really looking at in the context of this study. 95% of cases were mild. There was one fulminant case that was fatal. But this sort of mirrors the experience with typical myocarditis. It's usually caused by viral infections, rarely by medications, almost always mild and self-resolves. So let's go and look at a little more detail of this. The timing tends to be shortly after the vaccine, within the first 2 weeks. And this shows the timing after the first vaccine dose according to gender, men and boys in the blue, women and girls in orange. And then below it after the second vaccination dose. And two patterns sort of, or three patterns I should say, show up here. One, almost all cases occurring in the first week after vaccination. Second pattern, more common among males than females. And the third pattern being that far more common after the second vaccine dose than after the first. And then if you look at the age groups, tends to be in the younger age groups. The single most common age groups were individuals in their 20s. And then, and that held for both after the first and the second vaccination dose. Again, more common among males than among females. Now, I think what's really useful to look at is, well, what actually is the risk here? We had seen these case reports, but with studies like this, we hope to get estimates of the actual frequency. And that's where this study, I think, is so useful. And here we're seeing the risk per 100,000 persons of getting a diagnosis of myocarditis after receiving the Pfizer vaccine. And that risk after the first dose is generally less than or 2 in per 100,000 persons, often less than 1 per 100,000 persons, depending on the age and the gender. Now, as we saw before, it is more common after the second dose. Among certain age groups, specifically young men, the risk approaches 10 to 15 cases per 100,000. Again, not a very big number, frankly, when you think of it as per 100,000 individuals, and keeping in mind that 95% of these cases were mild. So that's the Israel data, which seems really quite reassuring, at least with respect to the Pfizer vaccine inducing myocarditis. We also have data that were published later, just came out last month, actually. And these data from Italy summarize the incidence of myocarditis and pericarditis following vaccination with messenger RNA vaccines in individuals in the highest risk group, and those 12 to 13 years of age. It's a case series study from Italian hospital data. Helpfully, in Italy, these individuals were receiving not just Pfizer, but also Moderna vaccine. So we have some information about that vaccine as well. And the data set is quite large. Nearly 3 million individuals in that age group were vaccinated with the first doses between December 2020 and September 2021. During that period, 441 participants developed myocarditis or pericarditis, with most of those being due to the Pfizer as compared with the Moderna. However, the Pfizer was a much more commonly used vaccine. So we'll take a look in a few minutes here at the relative incidence according to vaccine. And the excess cases per 100,000 vaccinated associated with the messenger RNA vaccine was about 2 after the first dose, and between 5 and 6 after the second dose. When we look at the Pfizer vaccine, that excess risk was less than 1 after the second dose, and no excess risk seen after the first dose. So actually, generally a lower risk than was seen in the Pfizer, the Israeli study when looking at the Pfizer data. Interestingly, higher incidence with the Moderna vaccine than the Pfizer vaccine. The risk increased after the second dose and in the youngest for both vaccines, again, consistent with what we saw in Israel. It remained moderate following vaccination with the Pfizer, but was higher in males following vaccination with Moderna. There was 1 death in this cohort study, but it was almost certainly unrelated to vaccination. It was a case of pericarditis that developed about 2 months after the second dose of the Pfizer vaccine. And the death itself occurred over a month following the diagnosis of pericarditis. So it seems unlikely to have been related. So here graphically, we can see some of the data. from this. In terms of overall gross number of events, again, there were more with the Pfizer vaccine than with the Moderna, but that's only because so much more Pfizer vaccine was used in Italy as compared with Moderna. I think what's more relevant is looking at individually the excess risk associated with the Pfizer, as shown in this table or graph, and we'll look at the Moderna vaccination risk in just a minute. But you can see how the number of excess cases per 100,000 was less than 1 throughout after that first dose, and even after the second dose in the highest risk period. Now, with the Moderna vaccine, there was significantly higher risk than that. Even so, even looking at the highest risk group, so young males after receiving the second dose of this vaccine, the number of excess cases per 100,000 was still less than 10. So, so broadly speaking, I hope I've made the case that we have a couple of very large studies so far that are showing that while pericarditis and myocarditis is a risk after COVID vaccination using the messenger RNA vaccines, that risk is actually quite small. And furthermore, the vast majority of cases are quite mild. And I think by contrast, it's worth looking a little bit at, what are the cardiovascular complications of COVID infection itself? And they're really actually quite severe. And we're starting, we've always thought of COVID as primarily a pulmonary illness, but we're really starting to appreciate the effect it has on the heart. For example, myocardial injury with an elevated troponin level, and that elevated troponin level, of course, is a marker for cardiac muscle damage, has been found in up to 17% of patients hospitalized with COVID-19, and between about 1/4 and 1/3 of those admitted to the ICU. In fact, one study suggests that up to 7% of COVID-19 related deaths were due to myocarditis. So the myocarditis that occurs in COVID-19 illness can be quite severe, very different from the very mild myocarditis that is seen following COVID vaccination, also far more common. Now, it just, myocarditis, and part of the reason I present this is because it's so important to be able to diagnose it in people with COVID. It often presents with chest pain, shortness of breath, dysrhythmia. In severe cases, you actually get left ventricular dysfunction and symptoms of acute heart failure, like crackles on the lung exam, or even edema in the extremities that's new. You may see abnormal troponin values if the damage to the myocardium is extensive enough. Individuals who have this will often have an EKG that can show a range of findings, which will often mimic acute coronary syndrome with non-specific ST segment T-wave abnormalities, T-wave inversion, and PR segment, ST segment deviation. So when we have a patient who, is presenting with possible cardiac symptoms, usually the first diagnostic test we reach for is the EKG. It's fast, it's cheap, and it can give you a wealth of information. And this is a case report of someone who turned out to have COVID-related myocarditis that not only generated an EKG that looks all the world like they're having a heart attack, also induced new atrial fibrillation, and with these ST segment elevations that you see. So I think I'll just go ahead and stop there because I want to leave time for discussion and questions. So I'll open it up to the floor at this point and see what questions and discussions on items we can review.
Dr. Behrens, thanks so much again for the presentation. As usual, it's informative and really, really fascinating. So I'll open up the floor to anyone if they want to ask Dr. Behrens any questions or have any comments on what he presented. In the meantime, so while we're waiting for someone to ask a question, let me put one briefly. And one of the things I suspect might be happening is sort of a combination of COVID fatigue. Everyone's tired of COVID-19, and the fact that Omicron seems to be less severe. It is, I think people are getting complacent about, you know, the normal public health measures to prevent COVID spread, as well as vaccination and booster doses. Are you seeing that on your end as well? And how do we go about, do we need to change our messaging or reinforce what aspects of messaging? Just still reinforce with our patients, look, this is still an important thing. You need to get vaccinated, you need to get your booster, because it's good now, but what if? Because we learned from 1918 that it could get worse after it's got a little better.
Yeah, very good question. Absolutely seeing the same kind of COVID fatigue here in the United States. We're seeing a lot of relaxation that's of like masking rules that are actually here in Washington State going into effect this coming week. For example, at schools, it's going to be optional to wear masks. Masking indoor settings also going to be optional. And just by the way, I think that's not wise. I'm actually going to share my screen again because we are seeing an alarming sort of uptick in cases and admissions to the hospital in United Kingdom, also in Germany. This is in England. It's going up again in all the age groups, and somehow people don't seem to be paying attention to that. And it's not just England; it's other parts of Europe as well. Hospital admissions are rising also in all age groups due to COVID, and no one's totally sure exactly why this is happening. One possibility is, you may have heard of this BA.2. It's a subvariant of Omicron that seems to be more infectious. Reassuringly, it looks like the vaccines still work against that BA.2 subvariant, but it's, what's also unusual about this is that hospital admissions are rising at about the same time that the cases started going up. Usually there's a lag. And then of course there's, let's see, there's other parts in, these are data suggesting that the rise in cases might be due to this new BA.2 subvariant, and which is sort of cropping up in all of the United Kingdom. Let's see, we know it's more infectious. This so-called secondary attack rate for BA.2 is significantly higher than even the other subvariants or versions of Omicron. And it's really creating severe problems. And Hong Kong is having a terrible outbreak right now. It's maybe due to a combination of things. The BA.2 is probably contributing to that, but I guess long story short, I think this is not not a good time to be doing so much relaxation, because once you relax the rules, it's going to be awfully hard to go back. I don't, personally, I don't think we should be closing schools and going to lockdowns and all that stuff. No, not at all. But masking is actually really effective. There are some studies that have just come out this past week that speak to just how effective masking is. And if there's one thing we can keep doing, it's encouraging the vaccines and just keeping some simple masking guidelines in place. In terms of encouraging vaccinations, it's tough. I have a lot of patients who just won't get vaccinated or won't get the boosters, and it doesn't seem to matter that I'm their doctor and I know a lot about this. They seem to put more trust in what some random person said on Facebook about it. So, it's probably a common theme. There was a study, I haven't pulled this one out of my hat yet, but there was a study that was just published looking at people who get COVID. They're seeing a decrease in the amount of brain tissue, several months later. They can be measured by brain imaging like MRI. Nobody knows the clinical significance of that, but I don't know, maybe it's certainly alarming and could be conceivably used to try and persuade people. I think with every patient, every individual, it's got to be a customized approach that starts with trying to explore, well, why, what are your concerns about it? Why are you hesitant? What questions do you have? What can I answer any questions? And trying to be as empathetic as possible. Try not to be just sort of dogmatic about it. See if you can find somewhere to meet them, at their level and address their concerns. And I've had occasional success with that. So it's kind of a long-winded response in terms of both what I think should be the public health sort of posture right now, and perhaps how we can approach it with individual patients in terms of persuading vaccination.
If I may say something myself, Dr. Behrens, thank you so much for your presentation. It was very informative. And so we are at two different ends of the United States. I work for the health department in the state of Florida. And it's amazing that you are experiencing similar stumbling blocks as we are in the public health arena here in Florida. And I know you will agree with me that a lot of the reluctance and the defiance, I would call it, especially among our HIV, I'm not saying it's only within our HIV population, but more so because when they have a comorbidity like, a problem like HIV, of course they're at higher risk. But trying to communicate and get those folks and other folks as well to understand this is not a political issue. It should not be a political issue. And that's where we're having the biggest problem, I think. And I can only speak for the state of Florida, is that it has been so politicized that the concerns about public health has been thrown out the window by those who should be more responsible for it. And so right now at the moment, what we're seeing is we recently, last week, got a directive from our governor. And he literally went to speak to a university here in Florida to the students, and he told them, I guess they were all gathered in some form of an auditorium or the other to listen to him because he was visiting. And he told them, take off all these masks. They don't work. Why are you wearing masks? And of course, you're talking about young people between the ages of 18 and 22. And they were like, yeah, let's throw the masks away. So,
yeah. Although to their credit, there was at least one student who kept his mask on.
Good. So I know you saw that. And it is heartbreaking because I can speak personally about how well masks work. Since the COVID-19 came into our world in March of last year, and we as public health workers started wearing masks, I have not had a cold since then.
Yeah.
The common cold.
Same here.
Over 2 years.
I'm loving it.
It's amazing. I
Yeah.
mean, and so we were directed here at the health department, also by the governor, to stop wearing masks. And so people who are coming into our building, now this is the Department of Health, where people for all sorts of reasons are coming to the health department for vaccines, whether it's immunizations, for other things, for TB, whatever it is. And you're telling them they don't have to come into the building with a mask on. So, because that's the order, we chose ourselves within our department that we will continue wearing our masks because we have seen how effective it is. I've gone out into the field to, in my surveillance role to communicate with and to work with our HIV patients, and some of them would say to me, "Take off that darn thing. You don't need it," and whatever. And then you just have to calm down enough to say to them, "That's not what I'm here for. Let's talk about your HIV and you not being enrolled in care. What happened? Why are you not in care anymore?" And so you have to change the narrative so as to move forward, because there is so many, just too many forms of social media about people who are getting on stage and rallies and whatever and telling people that this is not real. And there's way too many people in the United States, and from what I understand, outside of the United States, who truly believe this is not real. I don't know what else we're going to say. I don't know what you can do to turn this around to a point where, healthcare workers, firefighters and police officers and all the others who are responsible for public safety are just not cooperating in the way that you would expect them when you have a public health crisis. So I think I'm just saying sometimes it could get really, really frustrating and really daunting, but I know I could speak for mask wearing if nothing else. I have not had a cold, and oh my God, it is so good to say that I have not had the sniffles or any coughing or anything for almost 2.5 years.
Yeah.
So it works.
Well, I salute you for fighting the good fight in the state of Florida, because I can only imagine just how frustrating and difficult it can be to have to confront this kind of stuff day in and day out. Yeah, Florida, unfortunately, your governor, as you know, has aspirations to be the next presidential candidate for the Republican Party, and to be taken seriously in Republican politics, it's kind of a litmus test. You have to be anti-mask, anti-vaccine,
anti-everything.
Yeah, and so yes, it's been absolutely terribly politicized by the Republican Party here in the United States, and anybody who really wants to make a name for themselves in the Republican Party has to go out of their way to, attack masking and all these, common sense initiatives that actually help. So I wish you all the best. Send you some strength. I hope to keep on doing the right thing in the face of, what just, an uphill struggle it must feel like.
Yes, it is. It is. But it's one day at a time. One day at a time. I think what's frustrating for us again is that we're in public health. That's our mantra. We try to protect the health of the public at large. But how do you get the public to understand that when your leaders are not supporting public health?
Exactly. Yeah.
Crazy. I see we had a
Thank
hand
you.
up from, thanks so much, Valerie. I see we had a hand up from Dr. Musa. Dr. Musa, you wanted to say something as well? Dr. Musa, you're very soft or you're muted. We're not hearing you so well. Not yet, not yet.
I'm seeing you were unmuted just. I'm seeing you unmuted just. Hearing you, David.
So perhaps you could type it first in the chat box and we'll take it up there. It's going in and out. It's going in and out.
Help to the rescue, very good.
Well, and oh, muted. It's muted now.
Hello? Hello?
Yes, we hear you now.
Yes,
So
yeah, you can hear me.
yes, so we hear from Dr. Musa and then
Yes, so we hear from Dr.
Honoré has his hand up after.
Okay, thanks. I said thanks, Dr. Behrens, for the great presentation as ever. Part of what I'm going to talk about, you basically alluded to, but I'm just wondering, because a number of countries, for example, Kenya, just declared yesterday that there's no more mask wearing in public places. It's a country where they have elections in the next few months. And I'm just what I think it's been said, we seem to be lowering our guards a little bit too early. But my main question is, based on the effectiveness and the duration of the vaccines and the boosters, are we heading towards a point where we might need more and more boosters, or is it after the first or second booster we're done?
Yeah, very, very good question. And I mean, the short answer is I think we don't know yet if we're going to need additional boosters. We know that one booster shot, makes a huge difference against Omicron. Really provides a lot of additional protection. And that's a bit of misinformation I hear from a lot of my patients that, I don't know where they're getting this. They're saying that the booster shot doesn't do anything. I suspect it may be due to, our finding that, the effectiveness of the booster shot in preventing any kind of COVID illness does taper off after, 5 to 6 months, but its protection against severe disease remains really pretty robust. So mishearing, misinformation about that, one booster shot really helps. Additional booster shots, at least against Omicron, I have seen some data out of Israel again. That was kind of disappointing. Israel tried, implementing a fourth shot, a second booster for, I believe it was all individuals over 65 years of age. And they did not see much of an impact from that, is my recollection. I just don't have the details at my fingertips. And so I think based on those data, nobody's really pushing at this point a second booster shot, but that could change. That could change as more data come in. That could change with, a new variant. We're just starting to see this BA.2 subvariant crop up. Maybe we'll, again, so far it looks like the vaccines hold up well against that BA.2, but that could change. It's, if there's one thing we've learned about COVID is, the story keeps on changing. And once we feel like we've reached a certain kind of equilibrium, and it throws another curveball at us. So I would say for now, we're not recommending a second booster, but that could easily change.
Thanks so much, Dr. Behrens. Dr. Honoré, you had your hand up as well?
I'm not seeing Dr. Honoré. I'm not sure if maybe he just got disconnected. So maybe you'll have to reach out to him so if you had a question, send it to us by email so he doesn't lose the opportunity. All right.
Okay.
So it's exactly 3 p.m. So I think it's a good note to wrap up on. So again, thanks to Dr. Behrens, and thanks to everyone for attending the session and making it interactive and dynamic. I mean, COVID-19 is an ongoing struggle, and we keep learning more and more things. I mean, I think we're all looking forward to the point where, even though it may not be permanently in the back window, and you know, we just leave it behind, at least the point where it's manageable, and we're not seeing spikes again and deaths going up and down, and having these, you know, ongoing tragic stories that have been sort of exhausting us as a civilization over the last 2+ years. So again, thanks everyone. It's a lovely Friday afternoon here in Port of Spain. A little cloudy, but not too rainy. Little blue skies, little sun. So thanks again, everyone. Be safe. Thanks, Dr. Behrens, again for assisting us with the program. The next ECHO session is going to be back on a Thursday in 2 weeks' time, and we'll be back with you again to share and spread knowledge, light and love through Mrftt, HIV, SCI, ECHO. This is bye-bye from me, Dr. Boyce. Stay safe and stay well. Take care.
Bye, everyone.
Okay, bye.
How do this